just wanted to say that it's really good to see you this morning, and also see lots of names that I don't know as well. So that's really great. Thanks, Canwell, for recording. I'm just going to share my screen. Canwell, can you just let me know if you are able to see that? Sorry, I can't see any of you, so if somebody can just let... Yeah, brilliant. Thank you. That's great. Canwell and I were just talking earlier about how frustrating it is that we can't see people when we're presenting on Teams, so glad that you can see it. Okay, so welcome everybody today to the webinar where we'll be launching the West Midlands Academic Health Science Network Human Factors Workforce Fund. As I said earlier, we are recording the session so that people who aren't able to join us today will be able to catch up. So what I'm going to do today is to introduce the West Midlands Academic Health Science Network's first Human Factors Workforce Fund. And we're really delighted that the AHSN will be supporting the development of human factors skills and projects across the region. My name is Fran Ives, for those of you who don't know me, and I am a Chartered Human Factors Specialist working at the West Midlands Academic Health Science Network. So this morning, I plan to set the scene a little by introducing the West Midlands AHSN and the team who will be working on the fund. What I'm then going to do is an introduction to human factors before telling you a little bit more about the Human Factors Workforce Fund. And we will, of course, have time for questions and hopefully some discussions at the end of the session. So we have two main reasons really for putting this webinar on today. Firstly, we obviously want to introduce people to the fund and hopefully get some thoughts and ideas that could turn into some possible projects. Also, though, we're very aware that the term human factors may not be familiar to some of you, but that really doesn't mean that you don't have some good human factors projects out there lurking that would be perfect for the fund. So by giving you an introduction to human factors this morning, I'm hoping that it will identify some possible thoughts and ideas, or you will be able to identify with some of the themes I'm talking about and understand its relevance to the work that you do. So some of you may be unfamiliar with the AHSN, so I'm going to give you a brief introduction. The West Midlands Academic Health Science Network is one of 15 academic health science networks, or AHSNs, across England. And as part of the national AHSN network, which is funded by NHS England, we seek and we test out and we accelerate the adoption and spread of innovative ideas and technologies with the potential to transform health and social care, both in the West Midlands, but also beyond as well. At the West Midlands AHSN, we have an ever-increasing team which brings together stakeholders such as NHS commissioners, NHS service providers, industry, academia, patients, carers and the public to identify healthcare innovations and successfully spread them at scale and pace across our region. So we enable and support collaborations between education, training, research, informatics and healthcare delivery. We offer networks where information can be shared and relationships can be built. And we provide an innovation pipeline, bringing new ideas together with industry expertise and investment. Just so that I can briefly introduce the team right at the very beginning. There's myself, Fran, Chartered Human Factors Specialist. I've been with the HSN since 2020, but prior to that, I worked for a number of years at University Hospitals Birmingham as a Human Factors Specialist there. We've also got Helen Hunt, who will be joining the call a little bit later. And she's one of our innovation program managers focusing on workforce. And we have Kanwal Umar, who is with us today, who is our assistant project manager. So anyone who does go on to apply for the fund will probably encounter all of us at some point. So I'm going to give you an overview of human factors now, because as I said earlier, I'm aware that some of you on this call may have limited knowledge or experience in this area. Now, I want this session to be quite interactive, and we are really only going to scratch the surface of this scientific discipline, but hopefully you will go away with a little more knowledge than you came with. So some of you may have not heard the term human factors, but you might have heard the term ergonomics or vice versa. The UK Chartered Institute of Ergonomics and Human Factors uses these terms interchangeably, so that's what I will do in this session today. So human factors or ergonomics is a scientific discipline, and it aims to ensure the design of equipment, so the things that we use and interact with, the environments in which we, say, work or spend our leisure time in, systems and interactions that we have with other people are designed to optimize human well-being and system performance. So I've taken that from the Chartered Institute of Ergonomics and Human Factors, and hopefully over the next few slides we'll be able to pick that apart a little bit and really drill down to what that means. But human factors and ergonomics, it's around us all the time. So anytime you've maybe engineered a product, tweaked a product, used a product, you've changed a process, or you've altered a system at work to make it work more efficiently with humans, then you have essentially practiced human factors. So the goal of human factors is to reduce human error, to increase productivity and enhance safety and comfort. But it has a specific focus on the interaction between us, the humans, and the thing of interest. So human factors is really a bridging discipline that brings together knowledge from subjects such as anatomy and physiology, psychology, engineering, to ensure that what is being designed complements the strengths and abilities of people, and it minimizes the effects of our limitations, because we have to recognize that as humans, we do all have limitations. So I often say to people that human factors help people succeed, and poor human factors, or the absence of human factors, can cause people to make mistakes and to get tripped up. Now, this is a diagram that I use quite a lot when I'm talking about human factors, and I've taken the diagram from the SEEPS model, which is the Systems Engineering Initiative for Patient Safety. Now, I don't want you to worry too much about what the SEEPS model is. The reason I've taken this element of the model is because I think it nicely describes some of the main areas of ergonomics and human factors. So at the centre of ergonomics and human factors are people. And as I said in my previous slide, it's really important that we understand people. We understand their anatomy, their physiology, their anthropometry, their biomechanics, and their psychology in order to consider and understand how they might interact with other elements of the system. The system being tools and technology, organisation, tasks, internal and external environments. So when you're looking at designing or creating anything used by people, think about all of those people who will be involved in the situation you're considering. Who are they? So in healthcare, they could be patients, they could be relatives, carers, doctors, nurses, AHPs, A&C staff, you know, the list goes on. Think about those people and think about the tasks that they're going to be required to do. So a task is whatever you're asking the individual to do. It could be a task that you're asking the patient to do, but equally it could be a clinical task that you're asking staff to do. Is that task a very repetitive task? Perhaps it requires steps to be done in a particular order. In any task, that people undertake, they'll usually interact with some piece of tool or technology. Now, that could be really basic or it could be very complex. So that tool or technology could be something like a pen or a chair, but equally it could be something much more complex like an anaesthetic machine. How is that piece of equipment used? What's it going to be used for? And then also thinking about the environment in which it's going to be used in. So in the SEEPS model, environment is split into two elements. You have the internal and the external. So thinking about the internal environment, that's things like temperature, layout, noise, etc. Whilst the external environment are usually things outside the organisation's control, such as regulations, laws, etc. So whatever you're asking people to do with whatever equipment they're using, they're going to be in some kind of environment, even if that environment is right in the middle of the countryside. And then the last element of the SEEPS model is organisation. So thinking about the structure of the organisation that people are involved in. Thinking about things like rotas, how have they been devised? How do we ensure that people have got the right skill mix? Have people working within the organisation got the right training? Have we got the right staffing levels? So when you consider each of these elements of human factors I've briefly mentioned, you'll be able to see that the human at the centre interacts with all of these. But in addition, though, there will be interaction between other elements of the system. So, for example, the temperature you're asking someone to operate a piece of equipment in may impact how it works. The organisation and the staffing levels may impact how a task is completed. So each of these elements interacts with one another. And if we make any change in one of those areas, we have to understand what impact it will have in the rest of the system. So I'm going to get you to sort of just do some thinking really to try and get your human factors hats on. And I want you to think about tools and technology. And what I often do when I'm using this exercise is to get people thinking about a piece of equipment that I'm sure you all own and I'm sure you all interact with numerous times a day, and that's your mobile phone. So I'm going to ask you some questions, and please feel free to type in the chat some answers as you're going. So I want you to think about your equipment, a piece of equipment that you probably feel very familiar with. And I want you to have a think about what the best thing about that piece of equipment is. So just have a think, and if you want to write in the chat what you feel the best thing about your phone is, then please do so. Now, this is an exercise that I run quite a lot, so we tend to see the same sorts of themes coming up again and again. I'm just seeing if I can have a look at the chat. Some people typing. Yeah, so have a look. So Suki likes the fact that it's a one-stop shop, so she can do lots of different things, make calls, manage diaries and access documents. What's really interesting there, Suki, is that lots of people say that I can do loads of things on my phone. I can check my bank balance, I can send emails. Not many people actually mention making calls, so it's interesting that you do. Jenny's talking about the ability to connect people, products and services. Steve likes the portability of it, so it fits into a pocket. That's great. So mostly when we do this exercise, the things that people come up with fit into different categories. So sometimes actually what people like is the aesthetics of it. So they like the way that it looks. Perhaps they like the colour of it or the style of it. Other times people like the usability of it. So they perhaps like the touchscreen element. They like the fact that it's quite intuitive. Mostly what people put, and it's true for today, is that they like the functionality of it. So they like what it does. So Stephanie's put about using all the different apps, taking photos. She's also gone on to the next question. So you've come up with some things that you really love about your mobile phone, and you can start to categorize it. So you think about the size, the functionality, the usability. I'm sure, though, there are some things that you don't like about your phone. So if there are any things that you don't like about your phone, any niggles, any irritations, then pop those in the chat now. This is very often when we figure out who has got iPhones with cracked screens. So things that people don't like, screen size, it can be too small to read. It can stop people looking and talking to each other. The functionality is reliant on network coverage, poor signal, slow, frustrating to use. So those are lots of the things that people don't like. Now, when I ask people to tell me the things that they like and the things that they don't like about pieces of equipment, often people find it easier to tell me the things that they don't like, because often when something is good, it's kind of just good. But actually, we really seem to notice the things that are irritations. And actually, if people can't come up with good things, or they struggle to sort of say what they really like about something, I don't necessarily see that as a negative, because sometimes I'll say to people, what do you like about this piece of software, for example? And they might just say, it works, it does what it needs to. And in actual fact, that kind of gets me punching the air a little bit, because if they can't find anything that they don't like about it, it probably means that there's been some good human factors applied. Perhaps the usability is being considered, the functionality is really being considered and then designed to suit what people actually want. It's often when things are missed, things haven't been designed particularly well, things are heavy, cumbersome to use, or they're really clunky, lots of button clicks. That's when people tend to notice. So when we're thinking about tools and technologies, we're always going to have gripes and things that we don't like about our mobile phones or any piece of equipment. And just looking at some of the things you put in the chat there's some quite different things. So if you all had a magic wand and made a change to your mobile phone to rectify all the niggles, you would probably end up with quite different looking mobile phones. So it's really important when we're considering making changes to things that we don't just make the changes that we want, we actually think about all of our users, and we make sure that any changes we make to pieces of equipment, to processes, to tasks will suit all of the users. So really thinking about that person circle right in the center of the SEEPs diagram. And we make sure that all of the changes that we're proposing will suit all of the users and not just ourselves. So here is an example of how equipment and environments can interact. So I noticed this road junction a number of years ago when I visited Sorrento, and it always stuck with me. Now, fortunately, I only navigated this road on foot rather than by car. But I want you to just think, and again, write in the chat, what do you think the challenges might be for a driver who was unfamiliar with the road and perhaps driving without a sat nav? So if you've got any thoughts about some of the challenges, or maybe you think it's an ideal junction. So just have a think. Would you know where to go? Would you know how to get to where you needed to? So we've got a comment, too confusing, too much going on, too many interactions. There are two different two-way roads side by side. Can anybody notice the signs and how legible they might be? I'll just give you another few seconds before I show you a close-up of the sign. Can barely see the stop sign. Yes. No pavement, paint is faded. And Suki's asking, where are the signs? I will show you the signs. So here we are. Here are the road signs. So not only are there 11 separate road signs, but they're all in different font sizes. They're in different colours. They're in different fonts themselves. And some signs are obscured by others. So if you were relying here on navigation by the road signs alone, it could probably prove fairly challenging. So here's a nice example of how tools and technology equipment interacts with other things. In isolation, each of those signs might look fine. You might think, yeah, it's nice and clear. We've got some nice black text on a white background. the arrows pointing in the direction in which it should, and the size of the font's great. In isolation, that might have looked fine. But when you actually put that sign in amongst the plethora of others, the situation becomes a lot more confusing. And actually, for road users who were unfamiliar with where they needed to go, it would just be a nightmare junction. So good design can reduce errors, it can increase efficiency, and generally contribute to a better user experience. But if we get it wrong, it can spell frustration or lead to some kind of errors. So thinking about people then, so different people will have different skill sets. They will come from a range of backgrounds. They might have differing needs. They might have differing expectations. So it's always really important to think about the people that you're considering in the system. What are their important characteristics? You know, what are the differences between different user groups? Do they have different attitudes, different motivations, different expectations? What are their physical characteristics that might be really important? So as I said with the mobile phone exercise, don't just design for yourself and don't just design for the average person as well, because they don't exist. So human factors specialists always really want to understand who's going to be involved in the work that we're looking at. And we want to understand what their attributes, what attributes are important, what we really need to think about. So if we were looking at designing a handheld device, for example, we would want to look at hand sizes. If we were thinking about designing an interface, we would want to look at text size. We would want to look at colours and the way that information was presented. If we were thinking about changing or designing a new work process, we'd want to think about how much we're asking people to do at any one time. Are we giving them a workload that's too high, or are we giving them a workload that's too low? Think about physical environments as well. So think about the complexities of them. So in a hospital, think about how pressurized our environments are, how complex they are, and how many people and technologies interact in that space. If you're designing anything, a new task or changing a task or an environment, you might want to really think about the impact that that environment has on the safety and efficiency of work. So think about the layout, think about the space and how it might be used. How might the ambient lighting, the temperature, or the noise affect the user and their ability to carry out their work? So the physical layout of an environment is really important. How is that room laid out? Is there a lot of toing and froing for people to access all the equipment they need? Are the items that the user is required to use located at opposite sides of the room? Is there enough space? Is there enough light? What's the temperature like? I saw an example of a pharmacy room in a hospital that had been fairly recently refurbished without any consultation with the users. Now, at first glance, the room looked really modern and it had lots of storage space. But then when I stood back and watched a member of staff moving around the room to gather the items that they use regularly, they were constantly hauling a footstool around the room as they went backwards and forwards, up and down, to collect items that were just really everyday, frequently used things. The diagram on the screen shows a clinic room that I was asked to go and look at some years ago, and staff highlighted that there were two main problems with this room. There was a lack of space and there was a lack of privacy. Now, it's really hard in environments where people feel it's too small to just get a sledgehammer out and knock through a wall. So we have to often be quite creative with the solutions that we think about. But it's also really important to involve the users here and understand how they use the space, what sort of tasks they do in the room. And also, a really important question to ask is, do you need everything that's in the room? Because so often we just get used to working in working environments that aren't brilliant, but we just get on with it and we put up with them. It's maybe that the environment was originally designed for something else and we're having to suddenly turn a store cupboard into a clinic room, and we just get on with it. But we don't always get on with it in the best sort of environment. So actually, when we were talking to the staff, we found out that no, they didn't need that huge long work surface because the cupboards underneath were actually empty and it was taking up a huge amount of space. We also talked to the staff and realised that they didn't need a couch as big as they had. So by being able to reduce those two elements, we were able to change the layout of the room and actually create a space at the top of the room, enabling them to have a curtain and create a bit of privacy. That also then freed up some space. So whilst the room was no bigger, it actually felt more usable for staff. So thinking about tasks, now we complete numerous tasks every day at work, and some of them may be operational tasks that we do routinely. However, there are always going to be tasks that are carried out less frequently or tasks that are perhaps carried out in exceptional circumstances or in emergency situations. It's really important that when any task is designed that we give due consideration to exactly what needs to be done by the user and who that user is. Ask questions such as what order do the tasks need to be carried out in? What type of information is required to complete the tasks? Will the user need to interact with any other pieces of equipment, or will they need to communicate with other users? Will users need to undertake any other tasks in conjunction with the one that they're thinking about? Because work is actually very rarely linear, but when we're thinking about changing things, we often try to put it into a linear scene and think about it without considering other tasks that are going on at the same time. Before moving into healthcare, I worked in the nuclear industry, and one of the areas of work that I undertook was looking at the procedures in the central control room. Now, I mainly looked at the layout of the procedures, the language used, but one of the really important parts of the work was understanding all of the steps within the procedure and working out how long each one took. Now, this was really important when we were looking at the emergency shutdown procedures, because if from the start of the procedure you've got 20 minutes before you have a core meltdown, it's no good if the procedure will take 30 minutes to work through. So thinking about the organisation, so just give you some examples here. How are the rotas designed? Do you have the right skill mix? Do you know everyone in the team? You know, there are going to be some instances where teams work closely together day in, day out. And in these situations, you tend to get to know people's personalities, their likes and their dislikes. If you think about a good scrub nurse who will know what a surgeon is going to ask for before they utter the words. But equally, though, there are teams that rarely work together and they have to very quickly establish a relationship and work together. So thinking about teamwork, coordination, collaboration, what's the work culture like within the organisation? What are the relationships and the management styles like? And how are work schedules organised? So we've thought about the application of human factors principles to tools, technology, organisations, environments and tasks. I appreciate this is a very brief introduction to human factors, but I hope it gives you an overview of the science and its importance to human work. Human factors is relevant to so many areas of the work that we do in healthcare. And good application of its principles can really contribute to successful work, but also improving the efficiency and safety of humans and system performance. Now, the best time to think about human factors is right at the beginning of a project, because it's much easier to change the size of a display screen or the text color, for example, at the prototype stage or at the time when you're really trying to sort of explore ideas and formulate your plans, rather than once it's all in and being used and you suddenly think, oh, I wish I'd thought about that right at the beginning. It's much harder to change at that point. So I've just put some links here which Camille will be popping in the chat. Just some real sort of signposters for places to go for other information. It's impossible to put all recommendations in one slide, so I try to just keep it very broad. the Chartered Institute of Ergonomics and Human Factors has got some really good information, particularly during the pandemic. They produced some guides, particularly related to healthcare, which may be useful guides on writing procedures. There's some working from home guides, so that might be worth a look just to sort of see how human factors can be applied to other areas of healthcare. There's loads of good stuff on Twitter as well. So I've recommended, if you are on Twitter, start with the Chartered Institute of Ergonomics and Human Factors and just see where that leads you. There's lots of really good stuff on there if you're interested in learning a little bit more. Okay, so what I'm going to move on to now is actually talking about the fund itself. So the West Midlands IHSN is launching a Human Factors Workforce Fund to support health and social care teams to implement human factors methodology to produce impacts we can measure and demonstrate within our work systems, and really specifically for our staff and for our patients. Now, we know that despite recognition that human factors will benefit patients and staff safety and system performance, healthcare organisations have really struggled to integrate human factor science in their work. There's very few healthcare organisations employing human factors specialists. So many of the human factors projects that are undertaken in the healthcare setting are done so by individuals or small groups of staff that have got an interest in the subject and a passion to make improvements. So we hope that the funding will help teams to overcome some of the barriers to implementing human factors innovations improvements in their work area. So some of those applying for the funding may well have their own human factors specialists, which is brilliant. But for those who don't, successful applicants will be supported by myself. So the HSN Workforce Fund will support the spread or adoption of a human factors innovation or improvement. So the fund aims to bring about tangible enhancements to workforce practices or patient experience within our region. So individuals and teams working across health and social care are invited to apply for funding of up to £10,000 to help overcome any barriers they've got in implementing their innovations or improvements. So as I said, as well as the funding, any successful applicants will also have West Midlands HSN support over a 6-month delivery period. So we're going to support teams to use human factors methodologies, which will help make measurable improvements to workforce and patients. And I'll talk a little bit more in some of the later slides about that measurable improvements. So any individual or team working in health and social care within the West Midlands geographical area is able to apply. So this includes Birmingham and Solihull, Black Country and West Birmingham, Coventry and Warwickshire, Hereford and Worcestershire, Staffordshire and Stoke-on-Trent, Shropshire, Telford and Wrekin. So individuals and teams working within health and social care within that region across the West Midlands, as I said, are able to apply for funding of up to £10,000, which will be awarded in the form of grants. Now, the value of the grants will be based on the requirements of each of the individual projects, and we are aiming to award up to 3 grants. Now, the grants could be spent in a number of different ways. So, for example, you might want to spend the money by freeing up some of your time, backfilling. You might want to buy in the time of, say, a research nurse. You might want to use it to fund time in the simulator or fund some admin time. You might want to use that funding to purchase some kit for testing, perhaps purchasing some informatics time to help with your data collection, data analysis, or you might want to use the funding to upgrade an IT system. So these are just some of the ideas of how funding could be spent. And at the end, when we've got questions and discussions, I'll bring in Helen, who's part of the fund team, and she can give some practical examples of how previous funds that the West Midlands HSN have supported have spent their funding. Now, in order to focus the projects, we would really like to align with the core 20+5 document, which is a national NHS E&I approach to support the reduction of health inequalities at both a national and a system level. So the approach really considers the most deprived 20% of the national population, so that's the core 20 bit. And this is considered alongside the plus bit, which is looks at ICS is determining population groups experiencing poorer than average health access, which isn't captured in the core 20 bit alone. Now, the 5 bit of the core 20+5 sets out the 5 clinical areas of focus, which are maternity, severe mental illness, chronic respiratory disease, early cancer diagnosis, and hypertension case finding. So what we're really keen to do is to support projects that focus on one of these 5 clinical areas. Now, I know Camwell will be putting a link in the chat to the core 20+5 document if anybody wants to go away and have a look at the document in a little bit more detail, or to just remind yourselves on what the 5 clinical areas of health inequalities that we want to focus our attentions are. So in order to further support the region and the development of human factors integration, we are going to be looking for projects that are able to show a measurable impact. Now, it is often difficult for us to really show the value of the human factors work that we undertake, but it's really important that we do so, or we find ways to do so. And that's why it's really important to us that we support projects that are able to show impact. So we will then support the teams to develop case studies, videos, posters, and presentations that will really showcase those projects. And what we hope then is that we create a repository of case studies from healthcare organisations around the region that we can then share with others to hopefully support their cases for human factors development. So this is a really key thing, a key part of the application, something that I really want you to sort of think about, is how to show those measurable outcomes and really try and build that in from the project right at the very beginning. So key dates for the fund applications are now open, and we will be putting a link to Meridian, which is our platform where the applications can be made. The application form is open from this point on, so please feel free to submit those applications. You've got until Sunday, the 3rd of July to submit your applications. We will then shortlist the applications, and we're planning to interview on Friday, the 15th of July. So as I said, we're using our Meridian site to collect our applications. So there is a form on there that will just take you through a series of questions, collecting information about your application. So if you want to go on and have a look at some of the questions and help shape your thinking, then that's open for you to do so now. So all applications must be made through the Meridian website. So that's a whistle-stop tour to human factors, but also the fund as well. So I'm going to open it up to questions now. And I also want you to get you thinking about this question that I've put up. You know, you might be sitting there thinking, oh, that sounds really great, but so if there are any things that are preventing you from applying, then I want you to have a think about those. And I'd be really interested to hear them in the discussion. So I'm going to stop sharing now so I can see people. Camwell, was there anything in the chat that you wanted to in particular draw my attention to? Okay. Okay, great. So I'll put the question out there then. Is there anything that's causing you to think, oh gosh, I don't have time to do, you know, I'm not sure I can apply for this. Is there any barriers that you immediately spring to mind? Do we need organisational ethics approval before submitting our bids? I suppose it's thinking about it'd be useful, Steve, to think about whether that's going to be required. And if it is, it might well be worth starting the process. You'll know best how long that takes within your organisation. So thinking about the timelines of our projects, whilst it's not a requirement for us in terms of your submission to have that box ticked, if this is a project that is going to need ethics approval, and that generally takes a while to come through, then it might be worth just getting the ball rolling sooner rather than later. I'm just going to move to Jenny before. Yeah, Jenny, I can see your hand up before I go back to the chat.
Thanks for the presentation. Actually, I wanted to also pick up on that notion of ethics. To do an ethics application, you have to have a fully developed proposal. You can't sort of start the ball rolling and then somehow or other magically get ethics. So, so that in itself has got a challenge. I think it's a genuine challenge, and especially if you want to show the impact of the funding, then you want to have ways of disseminating that might hit different sorts of audiences than videos and case study reports, within a pretty narrow access arrangement. But I guess my question is around demonstrated need. So I've got a whole list while we've been writing the list, while we've been talking about all the things I've already thought, oh God, that needs to be sorted out. So the relatively small amount of money, but I know it needs to be sorted out. I can show you a video now. I can listen to a video now about the noise created by security baby tags in the postnatal ward. It's hideous and relentless, goes off all the time, and yet the people who work there are a bit accustomed to it. And so talk to me about demonstration of need for the project. I mean, it's be bleeding obvious to anybody who walks in there fresh, but people have been enculturated and accustomed to it and think it's the only way and necessary. So they just wouldn't necessarily see it as a high priority need, but it's hideous. So talk to me about demonstration of need.
Mm-hmm. It's just before I do, Jenny, it's funny you talk about noise in that environment. That's a piece of work that Steve Tipper has spent a long time working on at Coventry. So he may want to chip in with his demonstration of need there. You say it's sort of blindingly obvious that work needs to be done in that area. That's sort of a gut feel, I guess, from you and actually, or from other people. Or what is it that makes you think that is a possible project? What element of it?
Well, a number of elements. Okay, so it's not a gut feel. I mean, I could play you a video. If we're trying to create a restful, supportive environment for mothers who've just given birth to a baby, then there's tons of evidence out there that that's not the environment to do it in. So, and then just because the staff seem to accept it doesn't mean that it doesn't impact on them as well.
Yeah.
There's lots of noise going on and lots of triggers to do something. So, you can argue that, but they don't necessarily see it. So that's the other thing. And then, of course, they're £60 a pop. So these little tags they stick on babies are £60 a tag. And they fall off and get broken and la 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 la. So it's expensive. And if it's put on too tight, it falls off all the time. Alarm goes off. If it's too loose, if it's too tight, it can cause skin damage to this little tiny baby. So there's good need, but not necessarily recognised need in the service, and potentially no solution yet. So you'd want to use this money as part of exploring better ways of baby security for the postnatal ward. And I'm sure there are better ways, because they can even protect garments better than this in shops. So I'm not suggesting we should pin them, but there's going to be a better way. We just don't know it. So that goes hand in hand with that first question: demonstration of need by the organisation, e.g. the people in it. And that notion of funding a search for solutions as opposed to having a solution, and then forming partnerships to help get those solutions happening.
I mean, I think it would be worth looking at what research there is around on the consequences or the impacts of noise in clinical areas, but also in other industries as well. Because although the staff might have got used to something, as you say, that's not necessarily a justification for continuing as is. And actually, it might not be until a solution is implemented that they recognise what an impact it has actually made. So it might be that there are some suggested noise levels for areas that are similar to that kind of environment, if not that environment. So noise levels could be tested. It might also be possible to look at whether there are any incident reports or things that people won't necessarily have attributed to distractions from noisy environments, but actually when you drill down, there might be something there. Helen, did you want to jump in at this point?
Yeah, hi all, I'm Helen Hunt. Sorry, I'm a bit late. I had to go to another meeting. I work at the West Midlands INEQUALITIES, and I just wanted, Jenny sort of said, you know, this fund could be used for that. And I just wanted to sort of reiterate, having been at the INEQUALITIES for quite a number of years now and done other funds, I just wanted to sort of reiterate, absolutely, Jenny, that's how we see these little pots of money of things that aren't on the top NHS agendas, you know, that are hundreds of thousands of pounds, that staff have got these great ideas, actually, that proof of concept, even if it's actually a proof of concept that this doesn't work, because ethically that's still important evidence, isn't it? And so it was just to kind of build that confidence of absolutely, yes, this is the type of thing we'd want to see. And absolutely linking it to evidence. Like I know, for example, there was a quality improvement project done at the Children's around lights at night on the ITU so that the children could sleep. Again, that similar sort of concept, but and it's these little quality improvement, these little small scale projects that then build into the big, massive sort of change processes, aren't they? So it was just to kind of go, yeah, absolutely, this is the type of thing we'd want to see. Sorry if I've missed the gist, Fran, coming in.
No, thanks, Helen. It's useful to just have some examples. Hopefully, Jenny, that's given you some food for thought and some things to think about. If you've got any other questions now, obviously, really happy to discuss those, or we can have a separate conversation a little bit later. Yeah, go on, Jenny.
I've got a big question. You might
okay.
answer it now, and that's perfectly okay. You can just park me and I'll cope. But it seems to me that there are some super big ticket items that fit in with this broad program of work. So health, medical, or health, electronic health records, electronic medical records, hideous, time-consuming, repeating data. Hideous inconsistencies between what's in there and what's in that. I think that problem has not been quantified at all. So over here it will say she's having a first baby, and over there it says she's having a second baby, like key clinical information, incorrect. And who knows what the right one is? Or inconsistent, and therefore we don't know what the right one is. But there's other technologies that are used widely in maternity care. One of them is electronic fetal monitoring, continuous electronic fetal monitoring. It's an area of research that I'm involved in. It has zero benefits, zero evidence that improves outcomes for mothers and babies, and it's used more or less routinely and is hideously expensive. All it does is drive the intervention rate, which of course drives the activity, but reduces the productivity. Where do those projects go in the system? I mean, if you press clinicians and you say, where's the evidence? Eventually it goes, oh, there's not much evidence. No, there's zero evidence. So people do know, but they still just keep doing it. So this isn't the place for that, but you might want to just take me offline and deal with me later. Fine. But where do those projects get addressed? Because they are massive impacts on both health and budget.
And I suppose, Jenny, the fact that, you know, practices such as that continue when actually there is little evidence for them, I think means that probably people just don't have the time, or they to complete these projects. I think that's often the problem, and one of the things we're trying to address with the fund is, giving some funding may actually help backfill somebody or free up some time, because I think that's often the challenge, and it's easier to continue with the status quo than to actually take the time to step back and say something potentially quite controversial. Actually, I don't think we should be doing this. So I think, yes, it is a sort of a bigger question to ask outside of this project. And I know Steve Tipper, who's the human factors specialist from University Hospitals Coventry and Warwickshire, would be a brilliant person to speak to, because he's done a lot of work into the maternity area. So I think you'd probably find him quite an interesting and useful person to link up with. Thanks, Jenny. I'm just looking down the chat. Stephanie's asked whether if an improvement is not part of the core 20+5, will it be okay to apply? We are really looking for projects that fit into one of those categories. So ideally, those projects do need to fit into one of the 5 clinical areas. Hopefully, those areas are fairly broad. So we are hopeful that by picking those as a focus, we're not restricting things too much. And it will actually help some people, I think, to focus their projects. But yes, ideally, we do want projects in that area. I think that's all of the questions in the chat. Is there anyone else on the call that would like to either put another question into the chat or come off mute and ask? Nothing at the moment. Helen, were there any other examples of projects that you wanted to mention?
Yes, so to talk a little bit, you've not covered types of things I spoke to you about yesterday. Yeah, so we've previously done a safety fund here at the IHSN, and some projects that I've been involved with, just to give you a taste of, I know up to £10,000 isn't a lot of money, but just for things to think about. One local authority applied for only a few £1,000s. They were looking at the oral care of their care home residents to prevent pneumonia. And so it was to purchase resources and all the dental kits, and to go out and train the care staff how to brush the teeth of the residents. So that was very much about consumables and a bit of time of one person to go out and do some training, a little bespoke. As I said, only a few thousand. Another piece of work was around actually buying some information analyst time off someone to actually come and collect this data of a project they were doing, so they can analyse it. Because I'm very aware I'm quite aware of what are the barriers to people applying, and I'm assuming a lot of people are going to say time, because it is. We're all working incredibly hard over our hours. It's like, how do you fit this in on top? So I'm really quite keen to people to think, okay, this is my idea, and that person be sort of the central person, but where can we get other people in to help support with that? So is it with data? Is it buying out some time of clinicians? Do we backfill? I know that's not as easy as I've just said that. I'm not that naive. But is it analyst time? There was one project at the Birmingham Women's Hospital, so it was part of a bigger induction of labour programme, but we funded an element of a lower banded midwife assistant, like a healthcare assistant, that was going to do a proof of concept specific piece of work and audit that was going to feed the bigger project. So it's about linking these things as well. Actually, if there is a bigger program going on that obviously we wouldn't fund, but there's an element that you're struggling with, it could be that that could be what you look at. I'm just trying to think. Obviously, consumables. There are other people that have put in for apps, for actual pieces of software, for things they wanted to trial and test. So I think those are kind of the key things. And as sort of Fran said, we are at our IHSN, we are moving into the health inequalities sort of agenda from next year. IHSNs, we will be commissioned to be looking specifically in this area. So hence why, as I'm sure most government bodies, it's all about the levelling up at the moment. So just to sort of reiterate what Fran said, our commission from NHS England will be very much around core 20+5 and health inequalities. So Fran, anything else that I've sort of missed that you're thinking about?
No, I don't think so. I think what I'd just like to say to people is that we're really happy to have conversations. We don't expect many very specific questions at this time about the fund. This is more hopefully to get you thinking and considering some different options. You'll probably go away, have a mull over, let the information that we've talked about today just kind of filter through and digest it. If you do have any specific questions about possible projects, then we're really, really happy to have a discussion. So please just send me an email or anyone in the team, and we can have a chat through and hopefully just give you some ideas and some direction and perhaps some pointers before you put in an application. So yeah, I don't expect you to sort of suddenly have fully formed applications all ready to go. I'm sure you'll go away and have a think and a ponder. So just wanted to make sure that you're all aware that we're very, very happy to have further conversations. Just see if there are any other questions now. If there aren't, we will give you some time back. But happy to stay on and answer any further questions that might be there. No? Okay, well, it's been absolutely brilliant to see you all today, and thank you very much for joining. Hopefully, we've given you food for thought and some inspiration, and hopefully we'll be looking through some applications from yourselves very soon. So take care and please get in touch if anyone's got any further queries. Thanks all.
Do you want to stop recording?
Yeah. To do that. Yeah.
So Suzuki works with us, doesn't she?
Mm.
Right, okay.